Good morning, everybody, and welcome back to the UK Stroke Assembly live and in your homes. My name's Tony Banks. I'm Head of Conference and Events at the Stroke Association, and I'm also very proud Chair of the UK Stroke Assembly. So we're back for week 3 of the programme, in our second round of the programme actually, and this week we turn our attention back to stroke research. We've got a fantastic panel for you again this morning who we'll introduce shortly. Before that, if you've missed any sessions so far or want to catch up on some of the sessions over the last couple of weeks, you can visit our website at stroke.org.uk/UKSA virtual, where you'll find all of the webinars that we've hosted so far. And if you're on social media, please do spread the word. We'd love you to post about the sessions that you join or promote future sessions that are coming up using the hashtag Stroke Assembly. And we'd also like to hear from you. We'll be posting a link in the chat box shortly. And in our weekly email roundup, you'll also have a chance to feedback on these sessions. Tell us what you'd like to hear about more in the future, and tell us what you think about how we run these sessions. How do they work for you? Please do feedback. It's really vital that we hear from you in order to shape future virtual webinars for our audiences. As always, we want to hear from you today as well, so you can introduce yourselves in the chat box and use the chat box to pose your questions to our speakers. And as always, we have Natalie with us this morning to take your questions and comments. Morning, Nat.
Good morning, everyone, and welcome to today's session. As always, if you would like to share any comments or questions in the text box, please do use the chat function. You can find this on the right-hand side of your page, and if you scroll down right to the bottom, you'll be able to enter all your comments and questions into the text bar and submit using the little arrow key. I look forward to reading those as always.
Thanks, Natalie. So yes, please do post your questions and comments to our expert panel that we have this morning. And let's move on to that now, some introductions. We are really privileged to have some great speakers with us this morning to talk about stroke research. We're joined by Rubina Ahmed, who's Director of Stroke Association Research at the moment. We also have Graham McClelland, who is a Stroke Association funded researcher and is going to be talking about his work in emergency stroke care. And we also have Elizabeth Kay, who is a stroke survivor, and is going to be talking about her first-hand experience about her stroke and thrombectomy. Good morning, everyone.
Morning.
Hello.
Good morning. Hi. So very quickly, would you mind introducing yourselves? I know I've just done that for you, but just say a quick hello to our audience. Perhaps you first, Rubina. Good morning.
Hello, thank you for having me. So I joined the Stroke Association in the middle of the pandemic in April, and this is my first UK Stroke Assembly, so I'm really looking forward to the discussions today.
Oh, thanks for joining us. We're really pleased to have you here, Rubina. And Graham, good morning. Welcome to you too.
Good morning. I'm Graham McClelland. I'm a research paramedic with the North East Ambulance Service and a researcher funded by the Stroke Association working up at Newcastle University. And I'll tell you a little bit about my work in a while.
Thanks, Graham. We're really looking forward to hearing about your work this morning. And Elizabeth, good morning. Welcome to you too.
Yeah, I'm Elizabeth. So I had a stroke about 3 years ago. So yeah, I'm going to chat to you about that.
Thanks, Elizabeth. We're looking forward to hearing your story too. So we're going to move straight into it. First, Rubina, you're going to share a little bit about the Stroke Association's current research work that we're funding and our programme of research that we have. I know you've got some slides you're going to share, so we're going to hand over to you if that's okay, Rubina.
Yes, and hopefully the technology works. So I am going to share my screen now. And hopefully, can you see the screen? Yeah. Hello. So today I'm just going to talk to you very briefly about why we fund stroke research, how we fund it, and what's changed in funding for stroke research since the coronavirus pandemic. So why do we fund stroke research? Well, just briefly, so stroke research, of course, stroke is a condition that affects many people, and there are lots of other disease conditions out there. But actually, when you look at the amount of money that is invested in stroke, you can see that it's quite low compared to other conditions such as dementia and cardiovascular disease. We actually did a detailed analysis of stroke research, comparing the amount of funding that is given to stroke compared to the impact that it has on an individual's life, and stroke is really far down. And so we really see see at the Stroke Association research as a key area that needs funding, and also for us to try and influence other people to try and fund as well. So, and stroke research really does make a difference. So this is a few examples of the wonderful research we funded. And back many years ago, back in the 2000s, we funded, for example, the FAST campaign, and I'm sure everybody's heard about it here in terms of looking at face, arm, speech, and time to call 999. And through funding that research, we were able to show that actually by looking for these signs of stroke, people who weren't very familiar with stroke could still identify people who might be having a stroke, and that's really gone on to have a profound impact on the way that stroke is identified really early on and how it's managed. So it's great. And coming more recently, actually, I'm sure everybody's aware of all the apps and technology that's out there. And recently we funded this really cool app called Ava Park, which is a virtual world, and stroke survivors can practice to improve their communication, which is a problem for around 1/3 of people who've had a stroke. So right now the program is being tested with more stroke survivors to find out how people can use it for therapy. So you can see there's a wide range of research that needs to be funded, right from how to prevent a stroke through to how it can be treated, and then how it can be help people rebuild their lives after having a stroke. And so how do we fund stroke? So our research strategy, which I'm not going to go into, outlines our goals for stroke research and how we can plan to achieve them. So we have 3 key goals. The first one is supporting the future leaders of stroke research, and you'll hear from Graham later, who's a prime example of why it's so important to fund people who go on to do the research, because it's about funding the research leaders of the future. Without great researchers, we won't have enough of the high quality research necessary to improve our understanding of stroke. We need the best minds in science and in medicine to come together and really put their minds and their brains to solving some of the problems that we have in stroke. The second one is around increasing investment and awareness of stroke research. So as I've spoken to you already, stroke is very underfunded, but one of the ways we try and tackle this is by kind of speaking to other charities and other funders to raise awareness and the importance of stroke, but also by jointly funding with other charities. So last year, for example, we funded a project grant with a charity called Fight for Sight, which, because visual impairments are a huge problem for many people who have a stroke. So by funding together with another charity, we're able to just increase our investment and also bring in other charities into funding more into stroke research. And then our third goal is really to support research that can bring the greatest benefit to people affected by stroke. So we work to do this in a number of ways. For example, over 40% of our research is in the area of rehabilitation. Now, I'm sure you're all aware that rehabilitation and recovery after stroke is really vital for stroke survivors, but actually it's an area that just generally across the board, whether it's stroke or whether it's another form of rehabilitation, is quite underfunded. So we're one of very few funders who fund this type of research, and it's so important because it can help people to recover, adapt, and to cope with the effects of stroke. One of the things that we really do well at this charity as well is our patient and public involvement in research. So all the funding that we provide has patient voice input into the decision-making process. So we have our Stroke Voices in Research group who review all the applications that come in and provide the patient voice and say, well, actually, from a stroke survivor point of view, this research is really important, or actually this isn't. And that's taken into account in our decision-making process. And this year also, we've been leading something called the James Lind Alliance Stroke Priority Setting Partnership, which has been really exciting because this is about, so the first part was a survey, which looked to try and understand, just to try and get questions from people. What are the questions that matter to you as people affected by stroke? whether that's a stroke survivor, a carer, or a healthcare professional. What matters to you as a person affected by stroke? You know, what are the questions that research should be looking to answer? And through that route, we had over 1,000 responses, and we had over kind of 3,000 questions, and we're going through the mammoth task now, collating all that information and working out a priority list. So hopefully towards the beginning of next year, we'll get a priority list, which is based on the research that patients and carers and healthcare professionals see as a priority for them. So, and that will direct not just the research that we fund in future, but the research that's funded by many funders across the UK in stroke research. And lastly, we just want to thank you for your support. The coronavirus pandemic has had a major impact on the research we fund. A lot of the 75% of the projects that we funded had to be paused in some way due to the pandemic. And we're now starting to get back up to speed. People are learning how to adapt, and projects are adapting and getting back on track. And, you know, we've still been lucky to be able to fund some new exciting research this year. So, you know, we're still going, and despite the pandemic, we will be, we're still looking forward to funding some exciting research this year. So thank you very much for listening to me.
Oh, thanks so much, Rubina, for that really comprehensive overview of our stroke research work at the moment. We know our audience are really interested in stroke research, and I'm sure you've all got lots of questions you'd like to put to Rubina. We're really lucky to have you here with us this morning. So if you've got questions, please do ask them in the chat box, and Rubina, you're going to stay with us and we'll get to some of those questions at the end, if that's okay. But thank you for now. So we'll move on next to bring back Graham, and we're going to talk a little bit about Graham's work, which is some of the Stroke Association funded research work that Rubina was just referring to. So Graham, welcome. Thanks for joining us this morning. I know you've got some slides too you'd like to share, so we'll bring those up now and hand over for your presentation on stroke emergency care, if that's okay.
Thank you very much. All right, let's get the slides. Okay, can you see the slides now? Okay, are you able to see the slides? Okay.
All good.
Yes, we can. Great. Okay, thank you very much for this, and thank you for giving me an opportunity to come and talk to you about this. So I'm Graham McClelland, as I said, and I'm a paramedic by background. I'm going to tell you about my work, which the Stroke Association is funding on developing and evaluating pre-hospital interventions to improve emergency stroke care. So I sit between sort of three organisations. So I work for North East Ambulance Service, and a frontline paramedic by background, but I've been involved in research now for probably the last 10 years, and certainly the last 5 years with a particular interest in stroke, and the Stroke Association has funded my PhD in the past, which has set me up to do what I'm doing now. And the research and the work I've been doing has been based in Newcastle University, and there's a stroke research group, and I work very closely with Professor Chris Price, who again is very heavily involved with the Stroke Association. And it's the Stroke Association that's funded my work in the past and has funded me now to do this postdoctoral research. So I owe where I am to them and to the support of people like yourselves. And I'm interested in stroke because stroke it's a massive problem. It's a huge problem. The figure's 100,000 plus strokes per year. So that's a huge number of people. And for me as a paramedic, having seen, encountered, dealt with stroke patients sort of on the front line, it's something that I was very passionate and keen to improve, to understand, to do more work on. And these numbers are huge, and they're not going down, they're only going up, unfortunately. So there's going to be more stroke patients in the future, and therefore it's going to become an even bigger problem. We can and we need to improve the care we deliver and the treatment we have for stroke patients. And for most stroke patients, for most strokes that happen in the community, the first point of contact with the healthcare services is often the ambulance service. It's often paramedics like myself who are called out when somebody collapses, when somebody suddenly develops symptoms, when somebody's unwell. And not all stroke patients will go via the ambulance service, but certainly the bigger strokes, the more acute strokes, we are often the first point of contact, and we play a crucial role in getting stroke patients to the right care. And getting patients to the right care in the right time is really important. And there's this concept that's been around for 15 or so years now, this phrase that time is brain. And this is really important because stroke is a time critical condition. We treat it as a time critical condition. And this is because the treatment window is so short compared to a lot of other conditions. We know as minutes tick by, the injury worsens, as minutes tick by, the availability of treatment decreases and the effectiveness of that treatment decreases. So minutes count. Stroke is, for us, a time critical emergency. And as a paramedic, with all the training we have now, with all the technology that we bring on the ambulance, with all the abilities we have, there's actually very little we can do to treat a stroke patient in a meaningful way. We don't have any drugs that we can give you that will make the stroke better. The assessments that we do, once we've realized or suspect that you're having a stroke, the best thing that we can do is get you to the right care, the right people, the specialist stroke centres who can do the neuroimaging, can interpret it, can put it into the clinical context and can direct the treatment. So the best thing we can do is rapidly assess, rapidly identify that you're having a stroke and then get you to that place. And it's not always the local hospital anymore. It can be a distant hospital, a hyperacute stroke unit, a regional centre. Get you to that place as fast as we can. So time is critical and minutes really do matter in an acute stroke. So I'm going to break down the sort of different phases, the steps that happen from our point of view, from an ambulance point of view, in an acute stroke call, because then this will sort of put the work that I'm doing into context. So it all starts from somebody making that phone call to 999 or to 111, somebody realizing that they, their partner, their parents, their siblings, their kids, somebody's having some symptoms, something has happened, somebody is unwell, and that call triggers a response from us. And if we suspect it's a stroke, then an ambulance is going to be dispatched. And there's a certain time window between that ambulance being dispatched and getting to your home, your house, wherever you are. So the travel time. And that's determined by geography, by weather, by distance, by how many ambulances are available. But the travel time. Once we get there, there's what we call the on-scene time, how long we spend at your house, at your workplace, wherever you've become unwell. There's a certain time period of assessment, decision-making, working out what's going on, identifying or suspecting that you're having a stroke, and then making the decision that actually this is what we're going to do next. So once there's an assessment, treatment, decision-making time period at your house, your location. After that, we've got to get you to the hospital. And as I said, it's not always the local hospital. You might have a hospital at the end of your road, but if that hospital doesn't have a hyperacute stroke unit, we're better off taking you on a further journey and getting you to these regional hyperacute stroke units. So 10, 15 years ago, when I first started, every hospital had a stroke unit, but now that's not the case. Stroke care has been centralized like a lot of other care, because we realized and we know that getting people to centralized units who see more strokes, who are more au fait, more slick at dealing with strokes, gives patients a better outcome. So we're better off spending a little bit extra time, traveling a bit further, and getting you to a specialist stroke centre. And then there's this period where we're handing over to the hospital, and the hospital's taking over your care. And this should all happen in an hour or so or less, depending on where you are in geography. But call from initial recognition of symptoms to getting to hospital, we really want this under an hour. So some of the work that I've been involved in up in the northeast where I'm based, we looked at these times. We looked at how long it was taking us from call to getting stroke patients to hospital. And we looked at it over 7 years, so 2011 to 2018. And what we see is it's going the wrong way. We want this to be going either staying the same or preferably going down, because minutes matter, time is brain. We want to get people into hospital as fast as we can. But we see it's the time increasing year on year. And this is sort of, one, it's worrying, and two, it's what has inspired and underpinned the work that I'm going to be doing. But there is some subtleties in this. So the red bar along the bottom shows this call to arrival, this travel time. And yes, that's gone up, but we're traveling further. Not every hospital has a stroke unit. We can sort of understand a little bit about that. And also how we dispatch ambulance changed. We don't send a car now if we suspect it's a stroke. We send a double crewed ambulance because we know we need to transport that patient. So there is some changes there. The purple bar across the top, the travels from the scene to get to hospital, that's gone up a little bit as well. But as I said, we're traveling further, central stroke units, we can understand that. But the green bar in the middle, how long we spend at scene assessing and treating you, is the bit that's most worrying, because actually our care hasn't changed in not just the last 10 years, but now in the last 20 years. So why are we spending longer at the scene, assessing and making decisions before we get you moving to the place where you can get the right care? And this is not just a problem in the Northeast. So the National Stroke Audit recognised that patients are having a longer time period between the onset of symptoms and arriving in hospital, and patients who get thrombolyzed, this acute treatment with a roughly 4.5 hour window, again, the times are going up. And the ambulance service is potentially part of that. They're not the whole picture there, but we are contributing to those increased times when actually we should be driving the times down. So it's not just a problem in the Northeast, it's a national problem. And then if we look abroad, if we compare what our paramedics or pre-hospital care in the UK looks like against other countries, actually other countries, Australia, Denmark, the United States, their on-scene times, how long their paramedics spend with patients in the house, at the location, etc., they're shorter than us. And these are average figures, there's a lot in there, but actually it shows that it can be done quicker and that we need to learn from what's going on elsewhere and really try and drive down the times that we spend with you at the scene. So this brings me on to work package 1. So I'm being funded to do 2 real projects which are connected, but work package 1, what I'm going to be looking at over the next 3 or so years, and that's what paramedics do at the scene, at your house, at wherever we find you. What actions do we take and how long do those actions take? What is the decision making that goes on? What's the thought process? How do paramedics weigh up spending an extra 5 minutes in the house doing an electrocardiogram against transporting you straight to hospital and doing that ECG later on? How are people making the decision, and what fills that sort of half hour or so that we spend with you deciding what to go on? Because actually we don't know in granular detail, and enough detail to really make some changes, what's happening in that time period. You know, does everybody live on the 12th story of a block of flats and it's just taking its time getting up down the stairs? Is it the fact we're not recognizing it as a stroke when we go through the door? Is it the fact we're doing treatments and assessments that maybe we can shorten? We need to unpick this before we can really do anything with it. So my work's going to involve collecting a lot of data, talking to a lot of people, trying to find out what's going on, mapping out these timelines. Because once we understand those and understand the activities, we can hopefully develop an intervention and some teaching, some education, something to try and start driving those times down, because driving the times down matters and really leads to hopeful patient benefit at the end of the day. So that's what we want to do with work package 1. Look at the on-scene times and drive them down. So work package 2, the second part of my project. We all now carry in our pockets technology that's incredibly powerful. Your smartphone has more computing capacity than the computer that sent the Apollo rockets to the moon, they say. It can do amazing things, and I don't think we've really explored or utilized the technology that we have access to now to the best of our abilities in terms of driving forward healthcare. And this is what we talk about in terms of telemedicine or telehealth, using this mobile technology to drive forward healthcare. And there are examples of some ambulance services are looking at this around the world and within the UK, and certainly in my own service, we're using telemedicine now for non-acute patients, for GP referrals, for keeping people at home, but for acute patients, for strokes, for heart attacks, for trauma, for cardiac arrests. There's a bit of a gap in the evidence there, and that's what I want to look into. I want to look into how we use telemedicine, how we use this technology that we have to link up the paramedics, the pre-hospital care providers, with the receiving specialists, the stroke physicians, the consultants, the people who are going to be making the decision about your treatment when you get to hospital. Can we use this technology to smooth the passage of information, to reduce, the duplication of questions? Can we get the receiving consultant stroke physician involved in your care earlier, so that when we hit the hospital, things happen faster? They know what you look like when you're coming in. They've got a plan in mind. Can we shorten the timeframes? Can we knock minutes off the decision making, the getting you to the scan and getting you the treatment at the end? Can we use this technology that we all have now to try and improve the care? This is what we're going to look at. And we're going to look at it using something called normalization process theory. We'll look at what technology we're using, who's using it, how we use it in terms of, is it suitable for every patient? Is it suitable for some patients? How do we make that decision? And why, in terms of why would people change their behavior? Why would paramedics use this? Why would the hospitals adapt this into their care? It's making the argument about why people need to change their practice so that this becomes normal practice rather than a research project that's only got a short window, or that is only a temporary project. How do we get this into normal practice, so it's a usual standard care, so that everybody benefits from it? And although this is sort of new technology for us, there are pros and cons. Not everything, we shouldn't do things just because we can do things. We really have to weigh up the pros and cons. Will applying telemedicine increase the times that paramedics spend with you, but reduce the times in hospital? There's a trade-off here, and we need to really consider the pros and the cons and the benefits and the risks, not just in terms of what happens with the pre-hospital setting with the paramedics, but actually balancing that against what happens in the longer journey, right from onset of symptoms to actual treatment in hospital. We need to look at it across the whole pathway. We can't just look at what happens in the pre-hospital setting in isolation, because gains in the pre-hospital setting might be offset by losses in hospital and vice versa. So we need to look at this in the bigger context. It's not just myself that's doing this. I'm supported by a very knowledgeable and enthusiastic team of people. Professor Price, who you saw highlighted in one of Rubina's slides earlier on, who's a stroke physician. Professor Finch is an expert on behavior change, normalization process theory. Professor Norton, a cardiologist, but also an ambulance service medical director. And Professor Williams, a paramedic academic and leading light in pre-hospital care. But at the heart of this, Bill Lang, a patient, funny enough, an ex-paramedic many, many years ago, but now a stroke survivor, who's also a key part of our team and driving forward what we do. And we're hoping to involve other patients in the work as we go forward. So I'll just very quickly, because I realize I'm sort of running into time here, give you a brief overview of some of the other work that we're doing in this area and that I'm aware of. So I mentioned earlier that was the call. This is all triggered by the 999 or the 111 call. But how those call takers identify stroke, what the information is passed by you, the patient, the public, to those call takers, and how they trigger a stroke response is really not being looked at, apart from a little bit of work by UKSA and Caroline Watkins a few years ago. And we want to look into that, because actually, if we don't trigger the appropriate response, then everything gets delayed. And getting that first contact, that information right, that diagnosis right by the call takers is key to setting a chain of events in motion that leads to the best outcomes for patients. So we want to look at that as well. The FAST test was mentioned earlier. There's a lot of variations. There's a lot of development on the FAST test. We want to get involved in, and we are involved in looking at how this can be adapted, improved, which is the best version of the FAST test to be using moving forward. And then there's technology, and I think technology is really going to change what happens, because, as I say, pre-hospital care hasn't really changed in 20 years. But the technology that's coming through now, the blood tests, the EEG caps, the visors looking at asymmetry within the brain, and even to the point of CT scanners getting put in to ambulances, these technology, I think, are going to be game-changing, and hopefully in a few short years, once diagnostics change and paramedics And pre-hospital clinicians can identify stroke with greater accuracy and even identify the type of stroke and therefore direct people to the right treatment. So thank you for your time. I'm sorry I've taken up a little bit longer than I should have done. I hope that was of interest, and I look forward to taking some questions from you. Thank you.
Well, thanks so much, Graham, for that really fascinating presentation on your work. And I can see in the chat box there's loads of discussion going on around this. Please do keep commenting and put your questions to Graham. Graham's going to stay with us, and we'll take some questions from you and put them to the panel at the very end. But for now, thanks so much, Graham. Really appreciate that. I'm keen to bring on Elizabeth next, who's going to share her story about her stroke and talk a little bit about how research played a part in that. Elizabeth, thanks so much for joining us this morning.
That's all right.
We're really glad to have you here. Maybe you could start, Elizabeth, by just telling us a little bit about your stroke story, and in particular those early moments, if that's okay.
Yeah, so it happened in summer of 2017. I was moving into my new flat, and I'm really, really grateful because my dad was with me at the time. And I had a headache sort of that started maybe about 5-ish that kind of got gradually worse, and I just put it down to like the stress of moving. But then we were lifting some bags into the lift, and I just collapsed, just face planted the floor. And my dad, I think at first thought that I'd just fainted. But then he sort of sat with me for a couple of minutes checking I was all right. And as he was speaking to me and I was responding, I could hear in my voice, it was like really thick and it was slurred, and it was really strange. It didn't sound like my voice. And so I noticed that. But I still felt okay apart from the pain in my head. And I was like, I'm fine, I'm fine. He was like, I think we need to call an ambulance. Like, I'm going to call one now. And I was like, no, don't. Obviously, I'm glad he did now. But yeah, so he called the paramedics, and they were the ones who were like, can you say hippopotamus? And it was like hippopotamus, like, and then she was like, can you smile? And then when I smiled, she said, yeah, left-sided weakness. And that was when I first, because I'd seen the fast adverts as well, and that was when I first started thinking, am I having a stroke? But I still didn't really think that I was. And it wasn't until we got to hospital, and I think even the doctors were kind of reluctant to say that it was until I had the CT scan, and then it showed that I had the blood clot. So yeah, so that's kind of how it happened.
A hugely scary time for you, I'd imagine.
Yeah, definitely.
Can you tell us a little bit about what happened next? I know you went through a procedure called thrombectomy. Could you tell us if you knew anything about that at the time and what you know about that now, perhaps?
Yeah, I'd never really heard of it. But so when I first went in, they said to my dad, the team who would normally perform a thrombectomy have gone home now. So we're going to give her thrombolysis overnight to keep her stable. And my dad was like, no, get them in now. So I think him pressuring them they did get the team in, and they were able to perform the thrombectomy. So they went in through my groin and basically sucked blood clot out through my brain. And then subsequently after that, I had some swelling. So on that first picture on the left there, that's where they'd removed a part of my skull. So that's why it's like really swollen. This all happened within sort of the first day of me being in hospital. So I don't remember a lot. I kind of kept coming round. And I remember at one point my mum was like, oh yeah, I saw my mum and I said to her, I'm going to have an operation soon. And she was like, it's already happened. And it was very weird, those sort of first few days in hospital. It was kind of, you know, when you look at your reflection in a spoon and everything's back to front, that's kind of what it felt like. But I suppose I didn't really have sort of the time or the mental capacity at that point to really be scared. I was just sort of going with it. And I didn't really move anything for the first couple of days. And then the doctor who performed the thrombectomy, he came and saw me, I think, a day or two after the procedure. And that was when my toes started wiggling. And he was like, this is great news. This, you know, it's been a success. And that's a really positive sign. And then gradually over the next few days, my movement started to come back. But I was completely numb and it didn't move at all initially. But my leg came back first. My arm was a lot slower. It didn't move for probably about the first month. And I didn't think it was going to. But then it did. And we were all crying. I'm very happy about that.
Wow. I mean, it's some story, Elizabeth. And I think a lot of people online now will be relating to your story and I'm sure commenting and posting questions to you as well. Do you, having been through thrombectomy, what's your thoughts on it now as a procedure? How important is that procedure for people like you and others?
Vital, I would say, absolutely vital. I mean, I suppose every stroke's different, but for me, I'm positive that it made a massive difference. Like, because the doctors said initially when they'd done the scan, they spoke to my parents and they said, we don't know how bad this is going to be. She might never walk again. She might never speak. She might not know who she is. So I think the removal of that clot must have made a massive difference, especially because it was all done relatively quickly. You know, so that's the main thing as well. Time is so important.
Yeah, something that Graham was obviously just talking about in his presentation too. You've come a long way, clearly. Tell us about life being now. What's life like now?
Yeah, absolutely fab. So this is a year after my stroke. I did the run for the Stroke Association in the Manchester run in May. And that was just a great achievement because I never used to run before my stroke, but I think because I went for so long without being able to walk, I was just determined. I was like, well, now I'm going to run. So I run probably 2 or 3 times a week now. So yeah, that was a great achievement. We raised a couple of £1,000 in large part because my dad's business donated quite a lot. But yeah, life's great. So I'm a support worker at the moment for adults with learning disabilities and mental health problems, largely because of my stroke, because I wanted to work in a sphere where I was helping people. And yeah, I'm going on to study social work in about a week. So.
That's incredible. What a journey.
Thank
Elizabeth. And congratulations on the fundraising as well. We at the Stroke Association are incredibly grateful for your fundraising and the support of your father's business too. So thanks for that. Can you tell us a little bit about your involvement with the Stroke Association? Aside from the fundraising, did the Stroke Association help you in your journey?
Yeah, massively. I would say mainly for me, it was that they put me in touch with lots of other stroke survivors, and they really made an effort with me personally because they put me in groups of other stroke survivors, which were useful and I did enjoy, but obviously largely there were people sort of in the 50s, 60s, 70s. So I was like 23 at the time. So they made an effort to actually find other young stroke survivors and we could meet up for coffee and talk about our experience. And I found that really helpful because I think having a stroke, it can be a very lonely experience and you feel as though nobody really gets it. So speaking to other stroke survivors kind of helps you feel like, you're not alone and you're not going mad and it's okay to be sad and angry. And,
It's really good to hear about that support that you had from us as a charity. And again, I know people will be sharing similar experiences in the chat box now. Elizabeth, maybe just before we finish speaking to you, I could talk to you for a whole lot longer. I have loads more questions, but we are running out of time. I mean, we're talking about stroke research today. We've heard about the emergency care that you had. Just to sort of summarize the future for everyone, really, how important is stroke research and what difference do you think it will continue to make for people like you and others affected by stroke in the future?
I think one of the most important things, which is kind of, obviously underfunded because it's all underfunded, but the importance of ongoing physio, because I would say, I went to Salford Royal, which I think is probably one of the best hospitals in the country for stroke. And the care I received was excellent. Everybody on every level, it was great. So I feel like the initial care I received was just phenomenal. And then I was very lucky that I got physio provided by the NHS for, I think, probably about 2 or 3 months after my stroke, which is higher than a lot of people. But I feel like people don't realise that ongoing physio is really important. And I was very fortunate that my mum and dad were able to pay for me to have private physio once a week after that. And it's very expensive. So I think a lot of people aren't as lucky as me. And if you don't have that ongoing care, that really impacts on your well-being and how well you're going to recover. There's no doubt I wouldn't have recovered this well without the amount of physio that I had. So I think more research needs to be done in that area, and I think it's really important.
Thanks for sharing those thoughts, Elizabeth, and thank you for sharing your story. We're incredibly grateful. I know people will really appreciate you taking the time to talk us through your personal experience of stroke. And you're going to stay with us. We've got some questions and comments from the audience as we begin to wrap up this session. We're going to bring Graham back on, and also, unfortunately, due to a technical reason, we lost Rubina, but we are lucky to have more than one expert at the Stroke Association with us. And Laura, who's been at the Stroke Assembly before, has kindly offered to step in and help answer some questions if there are any. So, Laura, thank you for the short notice, but welcome back to the Stroke Assembly.
Happy to help. Thanks.
Thanks for being here. And Graham, welcome back. And we're going to bring Natalie on, who's going to tell us similar questions and comments we've had from our audience this morning.
Hi everyone. There's been lots of chat in the box this morning. Really nice to see all those comments come through. I'll try and get to as many as I can, and if I don't answer your questions today, we will try and answer those in our weekly emails that we'll send out on Friday. But just to start, I'll share some comments. So from Rubina's talk earlier this morning around sort of the FAST test, there's been a lot of comments around the positivity of the FAST test. One from Stuart in particular saying how passionate he is about the FAST programme as it saved his life. And Laura's kindly shared some links in there as well that people will be able to visit in the chat box. I do have some questions. One in particular, Laura, if I start with yourself, we understand that COVID at the moment has affected people who are identifying they've had a stroke and when they go to hospital and phoning 999. Lisa has a question that says, I understand that patients who have been seriously ill with COVID have also experienced neurological issues. Are these being classed as a stroke? And Laura, I'm not sure if you're able to answer these questions or give us an idea around maybe some of the figures that are coming through at the moment. Are people reluctant to go to hospitals? Are we seeing a drop in stroke cases?
Thank you, Natalie. Yeah, and I think Graham may well also be able to speak to this, given his role as a paramedic. But we do have evidence that there has been a drop in the number of people attending hospital reporting stroke, particularly in that initial lockdown period, kind of end of March to the end of May. There was a reduction, particularly among people who might be classed as having milder strokes, and obviously, you know, stroke is devastating, whatever form it comes in. But the kind of what would medically be classed as milder strokes, or perhaps transient ischemic attacks. So the strokes where the symptoms only last for 24 hours, they appear to be reduced. That data has come from a national audit programme for stroke care in England, Wales and Northern Ireland. And also there does appear to be some kind of link between stroke and COVID, but and I did include a link on the chat about about a news article we put up looking at the evidence. There have been reports of strokes in patients with COVID. It does appear to cause abnormal blood clotting, which obviously is one of the major causes of stroke. There's not enough evidence there at the moment, unfortunately, so we can't definitively say that COVID would cause a stroke. There does appear to be a link, and we're kind of reviewing the evidence as it comes in, and we are hoping to fund some research to investigate why there might be an increased risk of stroke if you develop COVID-19. Graham, I don't know if you want to add anything to that.
So I agree with what you said there. From the pre-hospital perspective, we certainly saw a big drop-off in stroke cases getting transported to hospital in that initial lockdown pandemic period. And I think there's data coming out now that stroke units admissions dropped off dramatically, not just in the UK, but around the world. Whether this was people not going to hospital, whether this was people presenting with symptoms later, I don't think we properly understand what changed, but the numbers definitely noticeably dropped off in terms of patients being transported. And I think the worrying thing is this sort of bounce back, this ongoing effect. People that would have presented with milder strokes or TIAs are now presenting later on, potentially with more serious injuries. And there's going to be, it's going to take years to really unpick this, but I think we definitely saw an impact because of COVID, and I think we're going to be unpicking this for a while.
Thank you both, Laura and Graham. I'm just going to pick out some comments as well. Graham, there's a lot of excitement around your next stage of research around timings. We have a few different comments. So one from Sonia saying, Graham, was really important to go quickly when I had my stroke and was in hospital within an hour and had some treatment which reduced my stroke. I've then got a comment from Gary that says he knew he was having a stroke, and when his wife called 999, it took over an hour and a half for the paramedics to arrive. When he was eventually in hospital, it was around 3 hours before when he was awaiting for the ambulance and to see a doctor. Some different outcomes there of time and engagement with the ambulance service, which I think we're going to see in your next stage of research as you sort of pick that apart and look at those stages. So lots of comments around that at the moment. and around people's experience is. So thank you all for sharing those. That's all. There's lots of comments to get through, but thank you for everyone who has shared that with us today. And as I say, if there's any questions that we haven't answered, I'll pick those out and pop them into our weekly emails.
Thanks, Natalie, and thanks to everyone for all the discussions that have been going on in the chat box today and the questions you've posed to our panelists. That is all the time we've got this morning. So I'd like to say a huge thank you, Elizabeth. We're really grateful for you sharing your story this morning. Graham, great to hear about your work. Good luck with everything moving forward. Laura, thanks for stepping in at the very last minute. And also a big thanks to Rubina, who had to leave us, sadly. Thanks to you all, and we'll hopefully see you at the Stroke Assembly again soon. And that is all the time we have. Thank you for joining this morning. As always, we're back next week, Wednesday at 11 a.m. for our next session, where we're going to be focusing on finances, and there'll be lots of tips and expert advice for you. Please post your questions to us in advance or join us on the day, and we'll look forward to seeing you next Wednesday at 11 a.m. But for now, goodbye and take care.